lecture for epilepsy and seizures is what we're going to cover this time. These are the objectives. They are the same as the last session or the last lecture objectives. We're going to be discussing the same things, but applying them to seizures and epilepsy. If you have any questions about the objectives, please let myself or Stacy know. These are the course learning outcomes. As you can see, again, there's quite a few. So I'll let you review these. You can pause this lecture when you view it later. And if you have any questions or comments, concerns, please, again, reach out to myself or Stacy, and we will get back to you as soon as possible. So we're going to start with seizure disorders. This is chapter 59. So I should back up for just a second. My name is Melissa Bigsby. I am completing my master's degree in nursing education through Aspen University, and Stacy has allowed me to present these couple lectures to you. So welcome, and thank you for allowing me the opportunity to do this. We'll start with seizures. Seizures are proximal, uncontrolled electrical discharge of neurons in the brain, interrupting normal function. May accompany other disorders or occur spontaneously without apparent cause. Proximal is a sudden reoccurrence or intensification of symptoms like a spasm or a seizure. The abnormal electrical signals rapidly fire in the brain, and they're divided into categories depending on where they start in the brain, the onset, whether they're focal, generalized, or unknown, and whether or not awareness is affected. So either there's focal awareness or focal impaired awareness. Whether or not the seizures involve other symptoms, such as movement, is another attribute that you want to pay attention to for anyone that's experiencing a seizure. Seizures resulting from metabolic disturbances are not considered epilepsy if seizures cease when the underlying condition is treated. So severe acute condition is alteration of intracellular osmolality, depletion of substates essential for cellular metabolism or membrane function, or intracellular accumulation of toxic substances. So those can be underlying metabolic causes are your hypoglycemia, hypocalcemia, hypomagnesia, magnesium, hyponatremia, uremia, and bilirubin encephalopathy. Seizures are metabolic disturbances associated with seizures include acidosis, electrolyte imbalances, hypoglycemia, hypoxemia, alcohol or barbiturate withdrawal, and dehydration or water intoxication. Barbiturates, if you remember, are CNS depressants. And just to remind you what water intoxication is it's a potentially fatal condition. It's a disturbance in the brain function that results when normal balance of electrolytes in the body is pushed outside safe limits by overhydration. Extracranial diseases associated with seizures are heart, lung, liver, and kidneys. The heart, you'll see ventricular arrhythmias. Cardiac arrhythmias can cause a sudden drop in BP resulting in syncopal episode. Lung is sleep apnea, COPD, interstitial lung disease, intrinsic pulmonary disorders such as oxygen deprivation, which can trigger seizures, and theophylline toxicity. It's a bronchodilator treatment for commonly used for asthma and COPD, which can trigger seizures. Liver is ammonia neurotoxicity, and kidneys are electrolyte imbalances. Extracranial disorders associated with seizures are hypertension, systemic lupus erythematosus, diabetes mellitus, and septicemia. Hypertension, which we reviewed with our last presentation or lecture, causes increased intracranial pressure. The systematic lupus erythematosus is usually associated with infection and metabolic complications. Diabetes is hypoglycemia. Septicemia is infection, encephalopathy, brain disease, damage from like a stroke or malfunction, and bacterial meningitis. Epilepsy is a condition in which a person has spontaneously reoccurring seizures caused by underlying chronic condition. In the United States, 3 million people have epilepsy. Increases are in our older adults. Currently, there are more than 200,000 new cases of epilepsy diagnosed in the United States each year. New causes of epilepsy are more common in African Americans and in socially disadvantaged populations. Males are slightly more likely to develop epilepsy than females. People at high risk to develop epilepsy include those with Alzheimer's disease or those who have had a stroke. The risk is also increased in persons who are a parent who has a parent who has epilepsy. So if you're a child of a parent that has a history of epilepsy, you are at increased risk. Epilepsy is usually well controlled with medication. Etiology and pathophysiology. Seizure disorders have many possible causes. The most common cause vary by age. Common causes during the first 6 months of life are severe birth injury, congenital birth defects involving CNS infections, and inborn errors of metabolism. So birth defects, we'll back up here. In utero, brain and spinal cord do not fuse together properly, which causes neural tube deficit like spina bifida and encephalopathy and encephalocele. Infections are usually accompanied by a fever, so the high fever that can cause the seizures. Errors of metabolism are rare genetic disorders in which the body cannot properly turn food into energy, usually caused by deficits in specific proteins or enzymes that help break down or metabolize the parts of the food. Etiology and pathophysiology. Common causes for ages 2 to 20 are birth injury, infection, trauma, and genetic factors like genetic encephalopathy. Common causes between ages 20 and 30 are structural lesions, trauma, brain tumor, vascular disease. Vascular disease, this refers to strokes. Drugs like cocaine, alcohol withdrawal, where you have to have a CWA, which is the Clinical Institute Withdrawal Assessment Score. It's a 10-item scale used to assess and manage patients suffering from alcohol withdrawal. Common causes after the age of 50 include stroke, metastatic brain tumors. Nearly 30% of epilepsy causes are considered idiopathic. Idiopathic generalized epilepsy, or IGE, is diagnosed when there is no attributed cause to the seizures or the epilepsy. So again, just to note, vascular disease are the strokes, and drugs are a significant factor with seizure disorders and with cocaine and alcohol withdrawal. So again, the CWA scale, the Clinical Institute Withdrawal Assessment, is that 10-item scale used to assess and manage patients suffering from alcohol withdrawal. Etiology and pathophysiology continued. In epilepsy, abnormal neurons undergo spontaneous firing. Firing spreads to adjacent or distant areas of the brain. If activity involves whole brain, generalized seizures occur. Cause of abnormal firing is unclear. So any stimulus that causes the cell membrane of the neuron to depolarize induces a tendency towards spontaneous firing. Neurons transmit information. Excitatory neurons produce an action by releasing the neurotransmitter glutamate. Inhibitory neurons stop an action by releasing the neurotransmitter GABA, G-A-B-A. A healthy brain has a balanced amount of glutamate and GABA. If the balance is off, for example, if there's a decrease in GABA or an increase in glutamate, a seizure will occur. Gliosis, scar tissue often found in the area of the brain from which epileptic activity arises, is thought to interfere with normal chemical and structural environment of neurons. This makes them more likely to fire abnormally. Changes in the function of astrocytes may play several key roles in recurring seizures. Astrocytes release glutamate, which triggers synchronous firing of neurons, which we just discussed. Therefore, drug therapy focuses on suppressing astrocyte signaling or decreasing glutamate release may be a mechanism by which to achieve seizure control. Medications that stimulate GABA receptors, like barbiturates, control excitation, resulting in decreased seizure activity. So that activation of the astrocytes by hyperactive neurons is one of the most crucial factors that predisposes neurons nearby to the generation of epileptic discharge. Genetic link. Genetic abnormalities may be the most important factor contributing to IGE. And again, IGE is our idiopathic generalized epilepsy. Some types of epilepsy run in families. Other types of IGE are related to abnormalities in specific genes. More than 500 genes could play a role. Other types of IGE are related to abnormalities in specific genes that control the flow of ions in and out of cells and regulate neuron signaling, or are involved with protein and carbohydrate metabolism. Genetic link, again, difficult to determine the role of genetics due to the problem of separating genetics from environmental or acquired influences. In some forms of epilepsy, families carry a predisposition to seizure disorders in the form of inherently low threshold to seizure-producing stimuli. So the person may have such a response in presence of trauma, disease, and high fever. Abnormal genes may influence the disorder in subtle ways. For example, a person with epilepsy may have an abnormally active version of a gene that increases their resistance to drugs. This may help explain why anti-seizure drugs do not work for some people. Clinical manifestations determined by site of electrical disturbance, and they're divided into two major classes, generalized and focal. The preferred method of classifying seizures is presented in your textbook in Table 59-6. The system is based on the clinical and the EEG manifestations of seizures. So this is the algorithm for classification of seizures. I believe this is what's in your textbook. If the patient is diagnosed with a seizure disorder, it is very important to classify the seizure type correctly. The choice of treatment depends on the type of seizure. Focal is simple partial. Electrical activity remains in limited area of the brain. An aura is often experienced by the patient. A generalized affects the whole brain. Absent seizures is a brief, sudden lapse in attention. Tonic seizure is loss of consciousness and rigid body. Clonic seizures are uncontrolled jerking. Atonic seizures are brief lapse in muscle tone, and myoclonic are brief shock-like jerks while the patient is usually awake and aware. Clinical manifestations may progress through several phases: the prodromal phase, oral phase, ictal phase, and post-ictal phase. Prodromal phase precedes seizures with signs or activity, like example, mood changes, or which can occur days ahead of time. The appearance of initial symptoms until full seizure occurs. The oral phase, with sensory warning, prepare and ensure safety. Perception of light, unpleasant smell, confusing thoughts and expressions are sometimes present. Ictal phase is with full seizures. It's from the first symptoms to the end of the seizure. The post-ictal phase begins with rest and recovery. It's an altered state of consciousness. Drowsy, confused, nausea, hypertension, and headache are common. Generalized seizures involve both sides of the brain and are characterized by bilateral synchronous epileptic discharges in the brain from the onset of the seizure. Due to the entire brain being affected, there is no warning or aura. In most cases, the patient loses consciousness for a few seconds to several minutes. Tonic-clonic seizures. These are the most common generalized seizure, and which is this generalized tonic-clonic, which is formerly known as the grand mal seizure. If there are known history of having tonic-clonic seizures or grand mal seizures, they are a risk for falls. So you need to designate the patient as a fall risk. They're characterized by a loss of consciousness and falling, body stiffness, tonic, and subsequent jerking of extremities is the clonic phase. Cyanosis, excessive salivation, and tongue or cheek biting may occur. The tonic phase lasts for approximately 10 to 20 seconds. The body will stiffen. The clonic phase lasts for another 30 to 40 seconds, where they'll have recurrent jerking, spasms, relaxation back to back. If the seizure lasts greater than 3 minutes or occur back to back, it is important that you call for help, EMS, charge nurse, other associates, etc., because the patient is at risk of status epilepticus. You'll need to administer lorazepam, Ativan, 4 milligrams IV for continuous tonic-clonic seizures. Breathing stops and is followed by cyanosis. Incontinence of urine and stool is common, and prepare your suctioning. Tonic-clonic seizures have a postictal phase for tonic-clonic characterized by muscle soreness and fatigue. This is also known as the recovery period. The patient may sleep for hours, may not feel normal for hours to days, and will have no memory of the seizure. Generalized seizures with the typical absent seizure or petit mal usually occurs only in children and rarely beyond adolescence. May cease as the child matures or develops into another type. May cease as the child matures or the seizures may develop into another type. Can be precipitated by flashing lights and hyperventilation. These seizures are typically very short in duration, and the hallmark sign is staring-like state. So again, the hallmark sign of petit mal or typical absence seizures are a staring-like state. Typical absence seizures, the petit mal, the typical symptoms are, like we just discussed, a staring spell or daydreaming appearance. They last only a few seconds, often go unnoticed, and may occur up to 100 times a day if untreated. EEG demonstrates pattern unique to this type of seizure. Again, they're very short in duration. The hallmark sign is the staring-like state, can be confused with daydreaming or a look of confusion, cannot talk during the event, will not remember the event. The electroencephalogram, the EEG, demonstrates a 3 Hertz cycles per second spike and wave pattern that is unique to this type of seizure. Atypical absence seizures are characterized by a staring spell with other manifestations, brief warnings, peculiar behavior during the seizure, or confusion after. They are longer lasting than typical absence seizures and may be associated with the loss of postural tone. They affect a specific part of the brain. There's 2 types. Focal, onset, aware, or simple partial. The patient is aware of surroundings. They occur usually in the occipital region and cause vision changes. Focal impaired awareness is complex partial. The patient is not aware of their surroundings, and they are usually found in the temporal lobe. Automatisms are motor symptoms like lip smacking or rubbing the hands together are often seen in these focal impaired seizures. The EEG demonstrates atypical spike wave patterns, usually greater or less than 3 Hertz. Generalized seizures, continuing here with the myoclonic seizures, are characterized by sudden, excessive jerking of the body and extremities. Can be forceful enough to cause a fall, and they only last a brief time, but may occur in clusters. So the takeaway from myoclonic seizures, or myo is muscle, clonic is jerking. So break down the word, and it's easy to figure out what's happening. Patient is usually aware of consciousness, unlike the tonic-clonic seizure, and they're usually, again, very short in duration. Generalized seizures, atonic seizures, involves tonic episodes or paroxysmal loss of muscle tone. Begins suddenly and the person falls. Consciousness usually returns by time person hits the ground. Can resume normal activity immediately. Great risk for head injury for these patients. The atonic seizure, are also known as drop attack seizures. Patients with this type of seizure often have to wear protective helmets. Tonic seizures involve sudden onset of maintained increased tone in the extensor muscles. The patient often falls. Clonic seizures begin with the loss of consciousness and sudden loss of muscle tone, followed by limb jerking. So we'll back up to the tonic seizures. The extensor muscle straightens or extends a limb or body part. The limb jerking may or may not be symmetric. So tonic means rapid and clonic means jerking. Seizure precautions like the padded side rails are necessary to protect the patient from injury. Focal seizures, also called partial or partial focal seizures, are caused by focal irritations. They begin in a specific region of the cortex. They produce signs and symptoms related to the function of the area of the brain involved. Focal seizures have a unilateral manifestations that arise from localized brain involvement. Focal seizures begin in one hemisphere of the brain in a specific region of the cortex as indicated by the EEG. For example, if the discharging focus is located in the medial aspect of the postcentral gyrus, the patient may experience paresthesia and tingling or numbness in the leg on the side opposite the focus. If the discharging focus is located in the part of the brain that governs a particular function, sensory, motor, cognitive, or emotional manifestations may occur. Focal seizures are divided according to their clinical expressions into simple focal seizures, the person remains conscious, and complex focal seizures where the person has a change or loss of consciousness, produces a dream-like experience for the patient. Simple focal seizures, the person experiences unusual feelings or sensations that can take many forms. Sometimes there's a sudden and unexplainable feelings of joy, anger, sadness, or nausea. They may hear, smell, taste, see, or feel things that are not real. Complex focal seizures the patient displays strange behavior like lip smacking, automatisms, repetitive movements that may not be appropriate. The patient will not remember any activity started before and continued during the seizure and usually lasts just a few seconds. Some of the automatisms are organized such as counting out change or picking items from a grocery shelf. Other automatisms are less organized, such as picking at clothing, fumbling with objects, real or imaginary, or simply walking away. Any tonic-clonic seizure preceded by an aura or warning is a partial seizure that generalizes secondarily. Second generalized seizures may result in transient residual neurologic deficit postictally, which is also referred to as Todd's paralysis. Focal seizures may be confined to one side of the brain and remain partial or focal in nature, or they may spread to involve the entire brain, culminating in a generalized tonic-clonic seizure. Many tonic-clonic seizures that appear to be generalized from the outset may actually be secondary generalized seizures, but the preceding partial component may be so brief that it is undetected by the patient, by the observer, or even on the EEG. Unlike the primary generalized tonic-clonic seizure, the secondary generalized seizure may result in a transient residual neurologic deficit postdictally. This is called Todd's paralysis. It's focal weakness, which resolves after varying lengths of time. Psychogenic seizures, also called pseudo-seizures, are psychiatric in origin. They resemble epileptic seizures. The accurate diagnosis usually requires use of a video EEG monitoring to capture a typical episode. Patients with psychogenic seizures frequently have a history of emotional abuse, physical neglect, or a specific traumatic episode. No EEG changes are detected on these pseudo or psychogenic seizures. Status epilepticus, a state of constant seizure or condition when seizures recur rapid succession without return to consciousness. Most serious complication of epilepsy, neurological emergency, can involve any type of seizure. Subclinical seizures are a form of status epilepticus in which the sedated patient seizes, but without external signs because of the sedating medication. For example, a patient under sedation for ventilatory support in the ICU could experience a seizure without physical movements. The healthcare providers caring for the patient may miss the seizure occurrence. Treat these patients with rapid-acting lorazepam or diazepam. Monitor for oxygen deprivation to brain. Seizure precautions include the padded side rails, oxygen mask, and suctioning. No NG, cath, or tongue blade should be used on these patients. Complications. Status epilepticus causes the brain to use more energy than is supplied. Neurons become exhausted and cease to function. Permanent brain damage can result. So these patients, once they come out of the status epilepticus, are exhausted. Tonic-clonic status epilepticus is the most dangerous, can cause ventilatory insufficiency, hypoxemia, cardiac arrhythmias, hyperthermia, and systematic acidosis. These can be fatal. Continuing with the complications, severe injury and death from trauma during a seizure. Patients who lose consciousness are at greatest risk. Persons with epilepsy have a mortality rate 2 to 3 times the rate of the general population. 40% of these deaths are epilepsy-related and are caused by accidents occurring during seizures, suicide, treatment-related death, death due to underlying disease, and sudden explained death in epilepsy. SUDEP, or sudden explained death in epilepsy, is higher in males, those on multiple anti-seizure medications, and patients with long-standing epilepsy. The direct cause of SUDEP is unknown, but it is thought to be related to respiratory dysfunction, cardiac dysrhythmias, or cerebral depression. Effect on lifestyle is the most common complication of seizure disorder. Social stigma still exists. Discrimination, limitation in employment, and education are important. Driving sanctions are also complications related to people diagnosed with seizures. The patient may develop an ineffective coping methods due to their diagnosis because of this psychological problems associated with having a seizure disorder. Just for reference with the driving sanctions, the Arizona driver's license law, or any applicants who have experienced a seizure within the past 3 months must undergo a medical examination, and the physician must submit the medical report to the Department of Transportation's Motor Vehicle Division. So, critical thinking question. What should you do if your patient who has uncontrolled seizures tells you he insists on driving and it is against the law in your state under these health circumstances? So this will definitely trigger your critical thinking skills, because what you'll need to do is have a large group discussion about your state laws, reporting channels, and suggestions for talking with the patient and its healthcare team. So involve the family, involve the primary care physician, involve advocates, whoever you can, to sit down and talk with the patient about their future behind the wheel. So now we're going to go into a case study. So this is a 54-year-old WL who reports experiencing periods of feeling suddenly disoriented. He is not aware that this is happening. His coworker told him that on several occasions she observed he was behaving inappropriately. WL's behavior consisted of lip smacking and facial grimacing lasting a couple of minutes, followed by disorientation and confusion. Fearing he had Alzheimer's disease, he made an appointment with a neurologist. What type of seizure is he most likely experiencing? The answer here is complex focal seizures. If you guessed that, you're correct. So with the simple focal seizures, he would remain conscious. The focal, there's an irritation in a specific area of the brain, which results in a strange behavior depending on the area of the brain. And there's a change or loss in consciousness or strange behavior. So complex focal seizure. Diagnostic studies. So accurate, comprehensive description of the seizure with the patient's health history is very important. EEG may help determine the type of seizure and help pinpoint the seizure focus. Many patients did not have abnormal findings for their EEGs. Please refer to Table 59-7 for more information on this. Ideally, an EEG should be done within 24 hours of a suspected seizure. Abnormal findings help determine the type of seizure and help pinpoint the seizure focus. Only a small percentage of patients with seizure disorders have abnormal findings on an EEG the first time the test is done. So I'll repeat that. Only a small percentage of patients with seizure disorders have abnormal findings on the EEG the first time the test is done. Either repeated EEG or continuous EEG monitoring may be needed to detect abnormalities. An EEG is not a definitive test because some patients who do not have seizure disorders